kidneys that are usually located here. We will see later on, huh? So you have a clue that you should be looking at the kidney at the level of T12 to L3 vertebra, because down here, from that one, you will be, of course, dealing with the ureters already. And there to the sacrum, you'll be meeting the urinary bladder. Okay, huh? So here pa lang, in the gross anatomy, you are seeing here, of course, oh, that's the ureter. So this must be the pelvis already, diba? Because actually the renal pelvis, if you know it, is that this is already the most proximal portion actually of the ureter. This is the pelvis, the renal pelvis, and then this is already the major calyces. Yes, the major calyces, which becomes the minor calyces. Because this is very important. These calyces are very important because, you know, these are supposed to be the medulla. The medulla. Okay, and these are the renal cortex. And the medulla pyramids, diba? The medulla are turned to become medullary pyramids because there's an extension of the cortex going there, and we call it the renal column of Bertins, diba? And you remember that this is so bloody here because we have here the glomeruli, and we have here the proximal and the distal convoluted tubules. And if therefore I'm mentioning now about the nephron, parts of the nephron, diba? So the parts of the nephron, we know that there are cortical nephrons as well as juxtaglomerular nephrons. So therefore, in the cortical nephrons, a small part, of course, of the loop of Henle would be going here, going down here there only of the medulla and then the cortex. Okay, but the juxtaglomerular nephrons, they're usually here. The glomerulus is usually here at the near the border of the cortex and the medulla, but their loop of Henle goes deeper, much more deeper, diba? And here in the medulla, therefore we should not make a snub, of the medulla. So therefore the medulla contains therefore the parts of the nephron, like let's say the loop of Henle and then the collecting duct. Okay, but you don't expect to see proximal and distal convoluted tubules as well as the glomerulus in the medulla. Do not expect. But here in the cortex, expect that we can have the glomerulus, the glomeruli, of course, the proximal and distal convoluted tubules. And if they are the cortical nephrons, we expect also to see tubules here at the cortex. We expect to see. Okay. But the much more important is that you should have a heart to remember that at the deeper port here at the medulla, the loop of Henle here are very important because they are actually the ones that participate in the concentrating ability of the kidney. Okay, so this is just a preparatory because we will be seeing a lot of pictures. So the ureters, always remember that there are 3 normal anatomic and physiologic constrictions of the ureter, and it is at the level of the uretero-pelvic junction, is the renal pelvis. Uretero-pelvic junction, then at the crossing of the iliac vessels. So these are the iliac vessels here, at this one, and then the uretero-vesicle junction here. So there are 3 normal anatomic physiologic constrictions of the ureters at the level of the uretero-pelvic junction, at the level of the crossing of the iliac vessels. So this is aorta, diba? So these are the vessels, and at the level of the so this is the iliac. This is the iliac. This one, the iliac, and then at the level of the uretero-pelvic junction, this one here. And which is the narrowest? The narrowest is the uretero-vesical junction. That's why if a stone, for example, there's a stone here in the kidney that fell off, that fell down, these are very important to note. The uretero-pelvic junction at the crossing of the iliac vessels and at the uretero-vesical junction. Very, very important because stones could lodge there when they will fall off from the kidney. So, but the narrowest among the three uretero-pelvic junction, of the three physiological constrictions is at the uretero-vesical, is the narrowest. That's why if the stone would, if ever there's a place in this ureter by which the stone would lodge, would be here at the uretero-vesical. Huh? So, the patient would feel painful, as if you're thinking that there's appendicitis. So that's one of the differential diagnosis for right lower quadrant pain. But you will notice that in urinalysis, the urine is so bloody. It's because these are stone. But in appendicitis, usually it's not a bloody urine, but the WBC count, it's very, very high. And the neutrophil stima, it's very, very high. And if it is also a reproductive female at the peak of her reproduction age, so what are the differential diagnosis if you have a right lower quadrant pain, appendicitis, doc, uretero-vesical junction stone? It could also happen here, huh? It could also happen here at this area. And the other one, doc, is ectopic pregnancy, doc. Yes, because if this is actually the uterus, for example, it's a female, the uterus is here. Sometimes the pregnancy is not within, but it is at the here at the fallopian tube, particularly the ampulla. So they would have the same pain. They will encounter the same pain in this area. So it's very important. Okay, so we go down. Okay, so hello. I'll call on one. How about you, Doctor? Okay, so Doktora. Oh no, so si Doctor na lang si Kuya Joseph. Dr. Joseph. Hello.
Hello, Doc.
Dr. Joseph, are you here? Okay,
Yes,
so good
Doc,
morning.
good morning.
So you will be first the one to speak or discuss in behalf okay, of your group and guests. So an IVP, an intravenous pyelogram, is basically actually an X-ray or a series of an X-ray of your kidney, ureter, and bladder system. Kidneys to the renal bladder done after some contrast material. Some contrast material ba? It is a dye that has been injected into your veins. The same contrast product will be excreted through your, remember, excreted through your KUB system and will appear on the X-ray below. So this one. Here, when you place a dye, a contrast material, you were able to color white this one.
Yes, Doc.
Okay. So these are the, so we have here, Doc, these are the minor calyces, became the major calyces, and then it become the pelvis, Doc,
Pelvis,
the ureter, Doc. So okay, and then the bladder. So it became ossified. Okay. So therefore, Doc, of course I won't expect to be seeing pa these structures, diba? These microscopic structures. You don't expect that one because it's already microscopic. So, but we're dealing with a gross. So for example, this one, we'll be dealing with a gross. But okay, so therefore, you don't see here, but you see the bigger ones. You don't see the microscopic pictures, of course, but presume that this is already the cortex. Presume this is the cortex and the medulla.
Yes,
okay,
Doc.
but this one is the sinus, the fatty tissue body, the sinus, or we call it the central echo complex in ultrasound. Okay, so therefore that corresponds to the area of your minor calyces, the major calyces. Okay, so you look at this. Oh, look at this. It's like that. Okay, like that. Meaning to say that it is not dilated. It is not dilated. It is the normal one. Because you know what, if you have a stone that will block here or block here, this will become like this. Oh, this will become big.
It will cause
Look at this.
hydronephrosis.
It's already big simply because there's a stone. Because there's a stone. Okay, so therefore, if there's something blocking there, the urine could not it is presumed that this one is right, normal. So that's why it's going there, di ba? Because
Yes,
there's no
Doc.
one blocking, meaning it is excreting well. But here, it is not excreting. Oh, it's not excreting here, and they become dilated. You call this therefore
Hydronephrosis, Doc.
hydronephrosis, hydronephrotic the kidney because the calyces are dilated. Okay, you call that as hydronephrosis, meaning to say the kidneys become enlarged with the enlargement of the calyces, di ba? Or of the
Yes, Doc.
pelvis, of the renal pelvis. We call this renal pelvis kasi. Okay. In ultrasound, there's also a counterpart of the term for hydronephrosis. You call that as pelvocalciectasia, di ba? Pelvocalciectasia. Okay, so pelvocalciectasia or hydronephrosis, if it's an X-ray, they're just saying, meaning to say that there is something obstructing there. That's why the renal pelvis, including the calyces, became dilated. Okay.
Doc, yes.
Okay, yeah. So one would be a stone, kidney, ureter, bladder, compared to, for example, I'll give you this one. For example, ultrasound only. So the ultrasound, look at this, the ultrasound, yes, you can see the medulla, you can see the cortex here. This is the renal column of Bertin, the one that is extending, okay? And you can see the central echo complex. And this is actually corresponds to the one that you see here. Diba, this the fats, diba, it's fatty man, the sinus is fatty man. That's why it's also very white. And you see also here the calyces, diba? The minor, which becomes the major calyces. These are the one. So these are the expressions. That's why when you call this in anatomy and physiology with Dr. Gasco before as the renal sinus, renal sinus, it is fatty, composed at the same time fatty and composed of the calyces. That's why ultrasound it's very, very hyperechoic. That's why it's very, very hyperechoic. And you call that as the central echo complex. Di ba it's hyperechoic? Central
Yes,
echo
Doc.
complex.
Hyperechoic.
Okay. So, as long as it is not dilated, look, as long as it is not dilated, meaning it is white. But if there is dilatation of that one, it will become black because there's
Hypoechoic.
something blocking in the flow of the urine. Okay, you will see that
Yes.
one later on. Okay, with further samples. Okay, that is the one. It's now black. It's dilated. You cannot anymore see the whiteness simply because there's a stone blocking. So the urine cannot get out. The urine cannot get out. That's why the urine will be going back. And that's the urine. So that's what you call a pelvocalciectasia. It's very different. Okay, so we start. So therefore, in ultrasound kasi, you will see the anatomic pictures, no problem with it. You can see the calyces, the central echo complex, you can see the medulla, you can see the cortex, but you don't see, of course, the loop of Henle's because it's very microscopic. But therefore, after all, you don't know if this is like an excreting kidney. You don't know simply because this is not dynamic. This is not, remember, this is not dynamic. You do not know if this is an excreting kidney. But in KUB, this one, this is KUB, intravenous pyelography. It is actually a study not just of the anatomy, the ureters, but it is also a measure the excretability of a thing. Remember, you placed a dye, you placed a contrast material, so therefore you expect that dye to get out. Otherwise, if this dye will not get out, the patient will die. Okay, it is there. It is supposed to get out, di ba? So just like with our substances, with antibiotics, like that, with our medicines, di ba? It should get out, di ba? The byproducts, or if you have toxins in your materials, or our normal metabolic waste products, they have to get out, di ba? Because di ba, urine formation is di ba, filtration, reabsorption, and secretion, and finally, it has to get out. The urine has to get out. So therefore, there should be from normal, there should be normal urine would be 500. The most maximal would be 2,000. So around 1,000 to 1,500 cc per day. That's di ba, the normal urine output. Okay, di ba ha? So therefore, there should be excretion, prompt excretion. Now, one good thing about IVP is that it can measure the extrability of a thing. You cannot just measure, you cannot just do that in an X-ray, you cannot just do that in an ultrasound. Huh? So look at this. Therefore, IVP is not just, it is not just an anatomic study, but physiologic as well, because it detects if kidney can excrete out a substance in our body promptly, meaning the kidney is functional. So take note of this example. Oh, so first you put a dye. Okay, you put a dye, ha? You put a contrast material to the vein. Of course, that is expected to go to the heart, di ba? To the inferior vena cava, then to the aorta, and then the branches of the aorta, it will now go to the kidney. So you expect them to be excreted na, ha? So therefore, going there. Okay. Okay, so diba? So that's the thing. Hey, because we have first year guests, of course, huh? That's why. And then remember, this is already a review for you for fourth year and the fifth year, because we are just human beings, diba? You have studied in first year, but you tend to forget, diba? As years go by, especially that you love to always to do Netflix nga ni movies, diba, Joseph? Your Netflix movies ba? So your tendency, don't study anymore. You're always there, going there. So we review. Okay, from here, okay, so it will go there to the inferior here for superior vena cava or inferior vena cava. Then, of course, from here, then from the right, so it will, of course, it will go to the right atrium, then right ventricle, then the pulmonary arteries, then go to the pulmonary veins, then we'll go to the pulmonary veins here, left atrium, then left ventricle, then aorta, di ba? Then 21%, di ba, Dr. Joseph, 21% of the cardiac output should go to the kidney, di ba? Because the kidney, of course, has to be given also oxygen, but at the same time, the toxic products of our body, they have to get out. That's why kidney is very important. That's why always when you do an IVP, IVP Doc, ha, Dr. Joseph and company, ha, and to all of you from Med 1 to Med 4 to medical interns, please, ha, don't forget talaga, ha, to have a testing, to have a test, ha. If this is allergy, because remember, this is systemic, the patient will die, Joseph, ha.
Yes, Doc.
The patient may die if you do not test. Because if it's, for example, it's allergy, it will be traveling. It will be traveling, it will go to the heart, then will go to the lungs, then it will go back to the, it will go there again. The patient will die. Huh? Okay, and be sure as well, okay, Dr. Joseph and company, that if you do a KUB IBP, be sure that at least the creatinine value of your patient, you try to look at first, creatinine, because it should not be more than two times the normal value. It should not be more than 2 times the normal value, because if it is more than 2 times, meaning to say that this is not excreting anymore. It's a contraindicated, because the substance, the IVP, meaning the substance cannot be excreted. It's toxic, so do not proceed. Okay, so as long as it is from normal or at least not more than 2 times the normal, you can, because there's a certain degree of excretability for that. So therefore, KUB is really a function of the KUB IVP, meaning KUB preparatory. There's a scout film, KUB, plus IVP, intravenous pyelography. So it is not just a measure, therefore, of the anatomic, but as well as the physiologic function. So how do you do it? So, okay, so once you have started already, of course, it will go to the kidney. So once the test is, you have already made a dye, okay, it will be this way. First, this is the KUB. This is the KUB, KUB component, the kidney ureter bladder. That's the scout film, preliminary film. Okay, so therefore, you have here the shadow of the right kidney. That's the shadow, the shadow of the right kidney there. Because I told you, watch out for if it is the T12, so T12, 1, 2, 3, 4. Around that one, I expect the kidney to be there. So that's the shadow of the kidney. So don't expect microscopic, of course, because this is just an X-ray. So okay, You try to also look if there are also very white thing, Dr. Joseph, You try to look if there's very, very white thing there, okay, Because it might be the stones, It might be stones, Because remember, you are subjecting your patient to KUB simply because you're suspecting there must be blocking thing, You try to look also, Dr. Joseph and company, to all of you, if there is a mass, because, for example, it is a female, there might be a big mass there, and it is myoma, Dr. Joseph, there's a myoma. It will be hindering. It will be hindering the flow of your ureter. So therefore, you will have a non-excretion. Later on, you will have a non-excretion. So, or if Dr. Joseph, look at this urinary bladder, Dr. Joseph, this is a urinary bladder area, di ba? This is a urinary bladder area here, di ba, no? For example, Dr. Joseph, you have a big prostate gland. If you have a big prostate gland, it will also impede the excretion of your urinary bladder. It will enlarge here the prostate gland. Therefore, it will block your urinary bladder. So therefore, there will be transmission of the flow going up. So you will have hydronephrosis. Here also, you will have hydronephrosis, So not only stones. So try to look at the scout film, okay, Now, after doing the scout film, you have a preliminary, so that preliminary reading on rate. So you try to look for the masses or something like that. Now, after injecting, make a film after 5 minutes. After you've injected, as long as there's no allergy, as long as the creatinine is at least not more than 2 times normal, you can proceed, as long as there's no allergy. So after put an injection, then after 5 minutes, you make a shot. It's expected that at 5 minutes, you have a positive nephrogram, meaning kidney. It is expected to be there, nephrogram, It is expected now to be at the kidney, So, therefore, you can see the calyces already, di ba? You can see that one, di ba? Positive nephrogram, good, very good, normal. After 10 minutes, you make a shot. So, after 10 minutes again, di ba, 5 minutes. After 5 minutes, you shot. Then after 10 minutes, you make a shot again. So expect that it will now be at the ureter. Can you see this one, Dr. Joseph and company?
Yes, po, Doc.
That's the ureter. Can you see this one?
Yes.
This one, no? Open your mic.
Yes.
So it's expected to be there. Otherwise, if after 10 minutes, it's there, no? So after 30 minutes, Doc, you make another shot. 30-minute shot, meaning 5, 10, 15. From the time you made an injection. So at 30 minutes, it is expected to be there at the urinary bladder. It is expected. So, if, for example, Dr. Joseph, there's a problem. Hala, Doc, after 5 minutes, Doc, I still cannot see a nephrogram, Joseph. After 5 minutes, you cannot still see this. So there's something wrong. Suspect that there is something wrong. Then, repeat. Shot 10 minutes after. Doc, I still cannot see. Doc, I still cannot see. Hala ka, Joseph. May problema ito. There's a problem. Okay. After 30 minutes, Doc, I still cannot see. There's a problem. There's a problem. So, that's why, di ba, you have studied, di ba, with Dr. Haya before, or with your nephro, whoever taught you nephro, we have pre-renal causes of renal failure. Pre-renal, we have renal.
Post-renal.
We have post-renal. So, give an example of a pre-renal. Doc, if there is, Doc, di ba, Doc, if this is a kidney, Doc, di ba, if there is, Doc, right, the right renal artery ba? The renal artery. Doc, if there's an atherosclerosis there, di ba? Doc, if there's atherosclerosis, it cannot go there. There's a pre-renal cause. Can you get me, doctor? Okay, Or if
anything that decreases the perfusion towards the kidney is a
oh, very good. Ang galing mo. Alam mo, Joseph, magaling ka. You're very good, but you're afraid. You don't participate so much in mga contests. You don't like contest, ano? But you're very good ba, ya? Okay, continue that, expose yourself more on mga discussions in mga outside of the group, okay? You're very shy type. You're shy type. Okay. So, sige. Okay, ha? So, nephrogram. Okay. Now, renal, doctor. Renal. Because,
Intrarenal.
remember, it might be, okay, stone, intrarenal stone. Ha? Stone within. Because, remember, there might be a stone here at the, for example, here at the calyx, huh? So it tries to impede. So it might be that the 5 minutes was just delayed. So actually there was still at that 5, but actually at 10 minutes, after 10 minutes na film, you can already see a nephrogram. It's just a bit delayed, simply because there was something blocking, huh? Okay. Now, give me example of post-renal. That's it. That's the one. The prostate gland.
Yes.
Prostate gland. Okay. Or the myoma. Huh? The myoma. So those are the things that you would like to consider. So therefore, in KUB, IVP, you are not just looking therefore at the anatomic. Like for example, in our patient kanina, previously, you have a stones. You see therefore, you will report this one as normal anatomic callus pelvic, di ba? The pelvises, the ureter, and the urinary bladder on the right, but promptly excreting right. Huh? But on the left, you have anatomic dilatation of your calyces, and that you notice a stone at the level of the non-excreting left ureter, non-visualized. Huh? So, most likely, after 30 minutes, this is still the one. It is therefore excreting kidney, but it is actually being delayed. Huh? So, after 30 minutes, what we do is that if it's not yet excreting 30 minutes, we delay 24 hours. After 24 hours, we make a shot again. Because at least naman, it will be excreted by the right. Huh? We make a shot. So, later on, you will notice that this will disappear simply because this one compensated already. Huh? Okay. But Dr. Joseph, there are patients in which there's really no excretion for the two. So, after 24 hours, there's no excretion. So, it's up now. You just report it's not for something. So what is important lang naman dito, Dr. Job, IVP really. Ha? Therefore, to know the anatomic and at the same time the physiologic or excretory activity of the kidney. Ha? Okay, can you get me, Dr. Joseph and company?
Yes,
ha? While in ultrasound, it is just anatomic. You don't know if it is excreting or not. Ha? Okay, so we go now here. Okay, we go further. Okay, so IVP is not just anatomic, but physiologic as well because it detects if kidney can excrete out a substance in our body promptly, meaning the kidney is functional. Okay, we go. So we know how to, you know how to do this, huh? So beware to have the creatinine muna, the creatinine level, and at the same time try to know if it's allergy or not, huh? Because you can be killing the patient, huh? Okay, so that's it. Okay, so it goes there. Okay, okay. Okay, so we have discussed that one already. Post-voiding, Dr. Joseph and company, try to look. Post-voiding, after 30 minutes, di ba, you shot it's there. So meaning, this actually an excreting normal, this is a normal KUV IVP actually. Then after 30 minutes, you let the patient void. It will really go out. Because it's already filled, so it will go out. That's normal. Okay. So let's therefore reflect more on the kidney. So we go now, not just to the anatomic gross, but we go to the histologic as well. So we invade the property of Dr. Lasaka. So, because, you know, di ba, my approach is usually CP, PRC, di ba? What is CP, PRC approach, Doctor? Clinico, Joseph, clinico, pathologic, pathophysiologic, radiographic, conference approach. So this is like a CPC. Huh? So we go further. So therefore, again, this is the cortex doc ano, yes. This is the medulla doc ano, yes. So the cortex also goes inside in between. Because there's the medulla. That's why the medulla pala is turned into medullary pyramids because there's an intervening cortical tissue here, which we call as the renal column of Bertins. Huh? Okay. So altogether, the cortex and then the medulla, you call it the renal parenchyma. Huh? This is the renal parenchyma. And this one is the renal sinus na. Huh?
Yes, Doc.
Which is composed of the fats and then the calyces. And also, we have there the blood vessels, the nerves, diba, entering the hilum, the kidney, diba?
Yes, Doc.
The lymphatics as well. Okay. And in ultrasound, this will look very bright. That's why you call it the central echo complex of the kidney. Okay, ha? So, we just have to stop there because there are just so many things that will be found here in the kidney. Okay, so give me one. Sige na, Dr. Joseph, you still remember? Or if
Yes,
you
Doc.
forgot, no problem. That's why we are reviewing. That's why we are here. Diba? Don't be ashamed. Okay, so one thing. So the nephron. Let's you review the doctor. That's the nephron. The nephron is composed actually of the renal corpuscle.
Yes, Doc. The
Diba? Renal corpuscle,
the
which is composed of your
the
glomerulus and
renal
your
tubules.
boma.
Oh, yeah.
Bumans capsula. Bumans capsule ang glomerulus, renal corpuscle. Then you have your tubules, which is composed of the proximal,
loop of Henle,
convoluted, tapos, sunod-sunod na lang loop of Henle, descending,
and
then ascending,
loop of Henle,
and then the distal convoluted
tubule.
Okay. And okay, the collecting duct depended to physiologist because the collecting duct kasi there are two stories about that. One half of physiologists may say that the collecting duct like gayton ba is a part actually of the nephrons in as much as the collecting duct daw emanates from the ureteric bud from the it emanates daw from the collecting duct daw emanates from the nephrogenic blastoma ba? From the nephrogenic blast cell ba? It started from the primitive kidney. That's why they say that the collecting duct is part of the loop of Henle. But other physiologists, they say that it is not a part. It is now not a part because it comes from the ureteric bud. Okay, so whatever it is, we usually refer kasi with Gayton is the reference. So we follow him, but do not be surprised when others would say they would disagree. Huh? But what is important is that both of them consider that part of the nephron is renal corpuscle, which is composed of the glomerulus and the Bowman's capsule, then tubules, proximal convoluted, and the distal convoluted tubule. Okay, and collecting duct for some and others do not include collecting duct. Huh? Okay. So, review lang, doctor. What are the parts of the nephron that are to be seen here only at the cortex?
The Bowman's capsule, the
renal corpuscle. The renal corpuscle.
Yeah, the renal corpuscle.
Which is composed of your glomerulus, diba?
Glomerulus, the
Bowman's capsule. And then ano pa? The proximal convoluted, and then the distal convoluted. Okay.
Yes.
Okay. Some tubules can be seen here at this portion if they are at the cortical nephron. Ano, di ba? If they are at the cortical, including the collecting duct, ha? If they are the cortical nephron, they can still be seen here. But if they are at the juxtaglomerular, meaning ang juxtaglomerular kasi, this one kasi is supposed to be here. The juxtaglomerular, it is here. So therefore, your proximal convoluted, your distal convoluted, your glomerulus are here. But the loop of Henle
are deep.
They go very very deep, di ba, Dr. Joseph? Ano?
Yes.
And including the Dr. Joseph, including the collecting duct.
Yes.
Of course, the vasa recta here, yes, very important, doctor, because they are the one that will receive, the one that are absorbed by the tubules. Ano, di ba? Okay, what is the counterpart, doctor, of the vasa recta if they are here at the cortex? The peritubular capillaries. Ano?
Peritubular
Yes,
capillaries.
that's the same because they will connect to the veins, di ba? Of the veins, so that all the substances that were reabsorbed will go back to our system. Okay, ha? So very good, Dr. Joseph. Okay, so which is the most abundant, cortical nephrons or the juxtaglomerular?
The cortical, doc.
More abundant, mga around 80 to 90%, but small amount will be the juxta. But juxtaglomerular is the most popular, actually. More popular compared with the cortical, because this is the one that helps in the production of a concentrated urine. This one. This one. Diba remember, doctor, when we discussed about the counter transport mechanism? Oh, galing mo. Ang galing mo, Toy. Ang galing mo. Sige, patuloy ka. Mahihain ka lang. Ayaw mong sumali sa mga makyub. Pag makyub na, umaalis ka na. Joseph, Joseph, can you hear me? Pag makyub, hindi ka na sumasali. Sumasali sila, sila Jestrel at saka sila at saka sila Corina. Kaya lagi silang may pera. Ikaw wala kang pera because you don't join. Okay? But you see, but you love to watch, di ba? You love to watch. Okay. Sige, okay, ha. Sige. So very good. Okay, ha. So therefore, in the renal column of Bertens, expect that you will all be seeing these one things here, Wow, very good. So in the medulla, expect only to see this one, the loop of Henle and the cortical. Okay. So what is the most pointed portion here in your medulla, doctor? This the most, the renal, the medullary, the renal papilla, the renal papilla before it enters the minor calyces, the renal papilla. Usually, this is the first one to be this very much distracted with a diabetic patient. It is a favorite board exam question. When there you have a distraction of your renal papilla, this one divides the medulla before it goes to the calyces, the renal papilla. This one, okay. This is there will be papillary necrosis kasi in diabetes mellitus. That's why the patient cannot proceed to deliver the urine and the excretory substances going into this one. That's why the patient will go into uremia or to something like metabolic acidosis, something like that, because of the patient having derangement in the excretion. Okay, they try to victimize the papilla. And remember, the papilla, they will drain there so that we can come here. So remember, the renal papilla. Okay, so we go further. Okay, that's what you were talking, doctor, So, therefore, the nephrons, the cortical nephrons, and then the juxtaglomerulary. So this is the more popular one because of the renal concentrating ability. Here, they don't actually participate, but they go for also for filtration, like that. All of them, the secretion, the absorption, all of them, they contribute, but the renal concentrating ability, the counter mechanism, the counter current mechanism, usually is executed by this one only. That's why it's very popular, although it is lesser. Okay, so we go down. So now, therefore, if you say ultrasound, doc, this is the medulla, this is the renal column Bertens, this one. So, doc, this is the papilla, no? This portion, yes, that is the papilla there. It's distracted in diabetes mellitus. Okay, Okay, so have a heart, therefore, in trying to know, So this is not just looking at that memorize, you just a picture, but there's some millions and millions of things to be known here. Okay, so if a stone obstructs here, the urine cannot get out, so you will have pelvocalctasia. Okay, sometimes naman, Dr. Joseph and all of you, stones, because remember the medulla, this is the medulla, man. This is the medulla. Okay. So, this is the medulla.
Yes, Doc.
Sometimes they become white, too much white there, because there will be calcium deposition there, which remember you have the absorption secretion process there. So sometimes if there's a derangement, you'll develop stones here on the medulla, which you call as medullary nephrocalcinosis. It's very, very white, the medulla, aside from the stones that also may develop here at the cortex. Depends. Okay, so we go further. So therefore, doctors, don't forget about this. Renal artery first, renal arteries, S, segmental, then interlobar here, then arcuate here, then cortical radiate arteries, or the interlobular, just the same, cortical radiate or interlobular. Then, therefore, it becomes now the afferent arteriole. So remember, afferent arteriole, juxta. Juxta. I know you're master of that because I can remember you answered well my question before. Juxtaglomerular, you have there your afferent juxtaglomerular cells, which are part of the juxtaglomerular complex. Juxtaglomerular cells, they are cells, they produce renin,
Yes,
for the regulation of the renin, okay? So, which is important for the conversion of angiotensinogen from the liver to angiotensin 1 to become angiotensin 2 via the ACE found in the lung. Then angiotensin 2, therefore, is a potent vasoconstrictor for the maintenance of the blood pressure, but it is not enough. For example, if the patient is being sensed as there is no perfusion going to the kidney. That's why the patient goes into secondary hypertension. So angiotensin 2, therefore, vasoconstriction will call on the release of aldosterone, diba? So that the aldosterone, distal convoluted tubule and the collecting duct will reabsorb the aldosterone, the sodium at the distal convoluted, the collecting duct, and water therefore follows, therefore increasing the blood volume. Angiotensin 2 is also very, very important because it also tries to, that's why you call it the RAS, renin, angiotensin, aldosterone, because if the insult is too much, it also tries to call on the release of the antidiuretic hormone. That's why it is the renin, angiotensin, aldosterone, RAS, plus ADH mechanism, and the antidiuretic hormone from the posterior pituitary gland, because the antidiuretic hormone will act on the collecting duct, to insert the aquaporin pores. Aquaporin, so ADH, di ba?
Yes.
Aquaporin, ADH, aquaporin pores, so that if you insert the aquaporin pores, water now can enter the aquaporin pores, so that it will add more, therefore in the increase in the blood volume, further, therefore increasing further the blood pressure. So what are the components, doctor, of the juxtaglomerular apparatus or complex?
JG cells,
JG cells,
mesangial cells.
yes, mesangial cells, and then the
I forgot the other one.
macula densa. Okay.
Macula densa.
The macula densa. You remember? Macula densa. The juxtaglomerular cells, because they release, of course, the renin. Then the mesangial cells, they are actually contractile proteins. And then they also actually help in the production of the erythropoietin, the mesangial cells. Then the macula densa. What is the macula densa all about? Okay, remember. So if this is your afferent arteriole, diba, which you have the JG cells here, the afferent arteriole, it is just near the distal convoluted tubule. The distal convoluted has the macula densa. The distal convoluted has the macula densa. So remember that if, for example, there's a decrease in renal perfusion, so if there's a decrease in the renal perfusion, natural from the afferent arteriole, because the afferent arteriole, diba, will become the glomerulus, diba? The glomerulus. So you will have the Bowman's capsule here. So if there will be no flow, di ba? Then the proximal convoluted tubule, then the loop of Henle, then the ascending loop of Henle, then you have the distal convoluted tubule here. If there will be no perfusion, so there will be less to be filtered. So therefore, no sodium will be sensed going there because there's no one filtered. Okay, there was one hypoperfusion. There was a blockage in the renal artery, diba? So what will happen? There will be less filtration, so less filter will be filtered. So no sodium. It will be sensed by the macula densa that you do not have sodium. So it will therefore call, they are just very near. It will tell the afferent arteriole to please produce more renin. Huh? Renin. Aside from the fact that actually the distal convoluted tubules, they also actually secrete renin, but very, very less only. The majority talaga will be released by the afferent, here, at the juxtaglomerular cells. Huh? So therefore, this one therefore is very helpful because it tries to augment more the juxtaglomerular cells, aside from the fact that the J cells kasi can sense naman talaga this going there, the more that more renin will be produced because this will be sensed that it will tell to produce more. So therefore, macula densa. So therefore, what are the three components of the juxtaglomerular apparatus? The juxtaglomerular cells producing renin at the afferent arteriole, then the mesangial cells which are contractile, and then the macula densa, which seen in the distal convoluted tubule, we try to sense if there is sodium there. If there is none, it will call on the juxtaglomerular cells to produce renin. Okay, ha? Okay, Dr. Joseph?
Yes,
Ha? Okay. Hello, Yanni. Dr. Akutana, you have now a more of a relationship with the juxtaglomerular cells, ano? They become your good friends na, ano? The kidney na, di ba? Before last Sunday, you were afraid of the first meeting, but now you are now
Yes,
happy.
Doc.
Yung kidney now is your best friend. Ako, di ba? Okay, so continue. We go. Continue. That's good. That means that's the start of learning. Ha? We start from simple things. We start from little things. Then later on, they become your best friend. Okay. So, therefore, memorize this one, ha? Renal artery, segmental, interlobar, arcuate, become the cortical radiate artery or the interlobular to become the apparent arteriole, of course. Because remember, from this, you will now be reacting with the JG cells, with the apparent arterioles, then the glomerular capillaries. Then, okay, remember, okay, filtration. There will start filtration there. But remember, ha? Even though Dr. Joseph and company, to all of you, that they go now to the glomerulus, not all actually will be filtered. There will be some substances which will really just bypass that one. But although majority will go filtration, they will just bypass. They will just continue to go to the efferent arteriole. They will just continue. And some of the blood, diba, usually water is being filtered here. But not all water will be filtered. Actually, some will just go here. Natural, diba? There will be, because how can you continue the flow naman if all of the water will be filtered, diba? So it will just go here. So remember, become the efferent. So remember, here, this is the one kasi that is being focused because we are going for the function of the kidney for excretion of the substances. But remember, of course, it's understood that you also have branches here from the efferent arteriole, diba, the efferent arteriole, so that it will go to become your capillaries na, because of course you will also be, diba, you have cells in the kidney. They also need oxygen. But of course, no problem yan. Kay the oxygen will diffuse man going to the cells, ha? For the perfusion. That's why, ay, sandali lang, ha? Okay. Okay, thank you. So, no wonder, this one is emphasized only because, you know, in the discussion of the kidney, this is the one emphasized because this is the one to be emphasized because this is the least understood. That's why we are mastering this. But for cells that we will say, kasi, Doc, how about the cells, Doc, of the kidney? Where do they get? That's just already understandable that from the oxygen coming here, of course, they can go to the cells. That's not anymore a problem. The problem to be understood is this one. Okay, ha? So, therefore, therefore, from the afferent arteriole, others kasi would just go, doctor, to efferent arteriole. But they have to be excreted. Some of the substances have to be excreted because they're also toxic. So therefore, once they reach na, di ba, efferent arteriole, then we go to the peritubular capillaries na. Okay. Once they reach na, okay, they will be secreted. They will be secreted, meaning from this one going to the lumen of the tubules. That's what you call as secretion. They have to get out so that they will be excreted out. Okay, Okay. Sometimes naman, doctor, sometimes naman, doctors, to all of you, right after they were filtered here, di ba? Most of the substances will be filtered here. Right after filtration, they will be secreted out. They will be secreted out at the proximal convoluted tubule. They will be secreted to the lumen to be excreted out. So it is not, therefore, filtration, reabsorption, and secretion. So secretion actually starts. It's not that it's the third one. No, it can coincide immediately. So it immediately acts. It's not that it's always the last. So it will be the late one. No, it immediately goes into. So mga antibiotic natin, the antibiotics that we took, they usually go out by secretion immediately. Okay, so that's very important. So therefore, from the efferent arterioles, the peritubular capillaries is very important because as you told me, as you told the group, that the reabsorbed substance will go back here, including, so this it should be peritubular capillaries and vasa recta. But vasa recta kasi, di ba, are at the medulla, at the deeper portion, while the peritubular capillaries are at the cortex. Because we have naman we have juxtaglomerular. The juxtaglomerular, the one deeper, the ones that are surrounding are the vasa recta count. And then the cortical nephrons, the ones that are surrounding, are the peritubular capillaries. But they have common thing. They will go to the cortical radiate veins, the interlobular veins. They will now become the arcuate veins. Then we go to the interlobar veins, and we go to the renal veins, because the substances that were now reabsorbed will be used by the body. So they will go back to the heart again, so that they will now be utilized by the body through the artery. Okay, so very good. Okay, so we continue. So hello, so Dr. Coritana, when you have a chat group with your med1, so try to also emphasize with this one. That's why how substances are now being circulated back. Okay,
Okay, Doc.
So therefore, this is very important. Okay, Okay, so this one, Dr. Joseph, it's actually the peritubular. They are the one actually counterpart of the vasa recta, but they are here at the the cortical nephrons. While this one, the peritubular the vasa recta are usually here at the deeper
medullary
portion of this one, medulla, because they are actually the one that will be encircling from the products of the juxtaglomerular nephrons. Okay, so this is very important in the counter current mechanism.
Countercurrent.
Okay, so wow, much reflection already about this, So therefore, Dr. Coritana, how are you related, Dr. Coritana, to our nurse? You are the retired nurse? Your mother? Grandmother? You do not know?
No.
So sige lang. Okay, no problem. Maybe I thought your grandmother or mother. So, okay, so Dr. Yani, now you should befriend her. You should befriend more the medulla, So
yes,
what are they? What are they? The lupabin lidok
Yes.
Then dok the
And the collecting ducts.
the collecting duct dok And of
Yes,
course, the
po.
vas recta dok
Yes.
Yes, very good. And then what's the most tip portion here in the
Renal papilla.
papilla dok. Oo. So kay if diabetic, it will destroy the renal papilla. So how can you get out the substances, di ba? That are to be taken out. So dangerous. So this is the renal column of Bertins. So you of course expect here some the nephrons here, of course. So very good. So you only see the distal convoluted tubule, the proximal convoluted tubules, then the renal corpuscle here, And some parts, of course, of the loop of Henle and the collecting ducts, if they belong to the cortical nephrons, okay.
Okay po.
And remember, the loop of Henle, they do not participate. They actually do not participate here in the in the concentrating ability,
Yes po,
But
Doc.
but both of them, this one, the tubules that you see here, the tubules that you hear, all the same. They also go for reabsorption, Okay,
Okay
and
po, Doc.
secretion. Okay. No wonder it's so bloody, the kidney so bloody, and that's why in the anatomy you will see that the cortex is really like reddish. It's because of the many tubules as well as the glomeruli. Here, wow, it's
Yes po,
because of the
Doc.
counter current mechanism. So this is the renal column of Bertins. This is the one. This one, the one I'm telling you here. Okay, So this just the same with the cortex here. Okay, so Dr. Curitana, what are the three ureteric constrictions normal? Ureteropelvic.
Ureter pelvic, ureterovesical, and
Okay. At the crossing of the
so
iliac
crossing of the
vessels,
iliac
and at
vessels.
the ureterovesical, which is the narrowest.
The
The
ureterovesical.
ureterovesical. So what is the importance of knowing this one? Because stones may lodge here. Okay.
Okay.
That may produce destruction of your kidney later on. And the most frequent by which they can go into is the ureterovesical, because the
Ureterovesical.
narrowest lumen of all. What is your
Yes po, Doc.
med, Dr. Curitana? What was your med?
Nursing po.
Where? RTR?
Yes po, RTR.
Where? What
Yes.
school? RTR?
RTR po, Doc. Opo.
Oh, okay, good. Okay. Okay, so this is a iliac vessel kasi, So it's prone. So can you get this one already, Doctora, So for your chat group, Doctora Curitana, so this is promptly excreting. This was a promptly excreting. That's normal, At 5 minutes, expected to be there the kidney, the excretion. Once you have
Yes
already
po.
put a dye, di ba? It should be there. That's what you call positive
Positive
nephrogram.
nephrogen.
Positive nephrogram after 5 minutes. So then after 10 minutes, it should be towards the level at the ureter already. At the
Ureters.
ureter. Okay. Then at the 30 minutes, it should be there already at
Urinary
the
bladder.
urinary bladders. Then we have here na the after
Excreted.
you void, post-voiding, will already get out. So meaning
Okay.
prompt excreting. So physiologically functioning. Aside from anatomically seen, physiologically functioning. So, by the way, Dr. Curitana and Medwan, now you know the reason, di ba, why I insisted the class on Sunday. Right
Yes.
after Sunday, di ba? Because others were complaining that why do we have a class doon Sunday afternoon? We just have first by monthly. Why can you have sleeping already a lot for Saturday? Di ba? And then you were already playing many games on Sunday morning. Then what is for 2 hours on Sunday, di ba? So, but now you know now, di ba? You have learned a lot. It only started with the Sunday school, di ba? On 2 hours only. And then Monday, when we started the class, you were all learning a lot. Now, I can continue. I have no hesitancy starting and going deeper because you have already learned on Sunday. That's why now tell the chat group, it really pays. The class really actually helped us a lot, But don't worry, we have no more Sunday after next Sunday. I have no more fears. So you can go on continuing Netflix again, Okay. Please.
Okay,
Okay,
Doc.
Okay. Basta continue lang. Basta just continue studying. Not only Netflix naman, Dr. Curtana, you will get fat, Oh, you do Zumba or anything that will make you perspire and inspire as well, Inspire by your love life ba? Okay, so
Okay po,
go.
Doc.
Okay, so sige. Go. So you know that one, oh, very good, That's why. That's the non-dilated calyces. Okay. But if you have a stone blocking, wow, you have hydronephrosis, you have dilatation of your pelvo-calyceal system. Look, they're ballooning ba? Normal kita na good. Oh, the normal is like a teapot. Look at this, like that, going like that. Diba? Ito man, Dr. Joseph, it's normal, nasa laki, Bagay,
Yes,
diba?
Doc.
Like a teapot, roll and stop. Diba? When you're still elementary, diba? Like a cup, diba? But then, now it's like golf, they're like balloons. They're ballooning, meaning they're dilated. Calyces, Okay. Okay, so this one, you call this as, in ultrasound, if you see that black thing there na, it's pelvocalictasia, meaning there's urine inside, where normally it should only be like that. Okay. That's why Doktora Curitana kanina, I was emphasizing this one ba, it's like that, because it's like this. This the one,
Okay.
The calyces nga ni, they're not dilated like that, Okay, you remember your elementary, di ba? I'm a little teapot, short ang stout, di ba, when you were elementary, di ba?
Yes po.
Okay, so like that. But if you have question, if for example you have a blockage here, wow, there go be like that, And there's urine here. Okay, that's it. One, Dr. Ayan, So this is equivalent to this one. This is the stone, Doctora. So it is at the uretero-pelvic junction, Doc. It's there. Oh yes, okay. Okay, this is the most proximal one. It's the stone. I will now, when we have a class already, further, I will now be ready to explain to you why is it that it appears like that on ultrasound. Why is it the X-ray it appears like that also? It will be for another time. We continue na lang. What's the time now, Doctora? What's the time?
10:19 po.
10:19. Okay, sige. Continue. So, a 65-year-old male patient came to ER with worsening hematuria, meaning blood in the urine. What is this exam? So, answer is IVP. Okay. The KUB is actually the scout film of the IVP. But if you also see the dye, already the white, that's already become an KUB IVP, But the other one kasi, this one, the preliminary film, Dr. Joseph and company, is the KUB component, kidney, ureter, bladder, because there's still no dye. It is just like a plain X-ray. But if you already place the dye, it becomes the IVP. So all in all, you consider this as KUB IVP study. So normally, it should be done in 5 minutes, after 10 minutes, and then after 30 minutes, then post-boil. There's a little modification when it comes to babies and children. But this is the standard one for adults. After 5, after 10, then after 30 minutes, then post-boil. Okay, so what's this, Doctor? What reminds you of this? Dr. Joseph, sige. And there's wow, cobra head deformity. Where can you see that one? So, Dr. Joseph, if it is in the board exam, cobra head deformity of the distal portion, these are congenital anomaly actually. These are congenital, but an obstruction lang. So, the congenital anomaly, cobra head, in the board exam, it appears ba in the medical board exam, cobra head deformity of the distal portion of the ureter. When you see that one in ultrasound or in an IVP, you can see that in ureterocele. Ureterocele, Okay, cobra head. Okay. Ureterocele. Next. Okay. So again, emphasizing largest again. So therefore, Dr. Curitana, this is your renal sinus, But in ultrasound, you consider that as the central echo complex,
Okay.
The central echo complex. But if it is dilated, it's already black na, because it's already filled with urine, diba? Okay. Okay, so wow, so again emphasizing this. You know, I am fond of going back and back and back again, so that it becomes familiar in you, Doctora,
Okay.
It's just priming kasi your mind. All of you, you're priming your mind. It's also nice to look at pictures. It's nice to look at pictures. Okay, go again. So, two types of nephrons. 85% of all nephrons are the cortical, located in the cortex, juxtamedullary closer to renal medulla, located extend deep into the, and this is very important for the concentrating ability of the kidney. Okay. Okay, this one. Okay, very good. So, this is the one, Doctora. This is the central echo complex. If it is not dilated, if there's no pelvocalictasia, it looks like that. It's because there's a fat and at the same time the calyces. That's why it's very, very white.
Okay.
Okay. And this is the medulla, Doctora. This is the medullary pyramids. So we have here the renal column of Bertin. Okay. Okay. So that's the normal kidney. Okay, So it's like that because of course, you see here the minor calyces, di ba, Doktora? Okay.
Yes po.
Okay, so there's a stone, therefore, Doktor, it becomes nawawala ito. You lose this one simply because you're now filled with urine because they're being blocked. The excretion is being blocked by the stone. That's why this one is a urine. So you put that as a pelvocalictation. Dilatation of the pelvo, kay pelvis man ini, and the pelvo of the pelvocalicial. It's the pelvis man. Di ba? It's a ureter. Di ba? Dr. Your Kuya Joseph ba, told you this is the pelvis. Di ba? The ureter pelvis. So, do you know your Kuya Joseph? Yan. He's a nurse also, he's from RTR. Can you see him there?
Yes po, I see him.
Iba
Can
na
you see
nga
Dr.
batch
your
ko
Kuya
ay
Joseph,
meron
fourth
nakaabot
year?
na, Dok.
Oh, yes.
Pero,
He's not there na fourth year, you're na first year.
okay.
The balog bangus. If no bangus, chicken. Sige, please. Okay, hello. So that's it, ha? So, we go. This one, doctor. Okay, so Dr. Joseph. So this one. This is the urinary bladder, Dr. Joseph. This is the urinary bladder, Dr. Joseph. So this is supposed to be the area of the ureter here. So where do you think is the one that is being led? The ureter vesicle. Ureter vesicle junction. This is a ureter vesicle junction stone. So this is kasi the ureter. Okay. So it's very painful actually, So Dr. Puritana, Dr. Ayani, no wonder if you have a stone here at the bladder, the ureter vesicle junction, you will expect pelvocalictasia simply because the pressure of the urine is blocked here. It cannot just go out. Therefore, it will be transmitted out the ureter. So sometimes the ureter becomes dilated as well because of the pressure. Like that. And that's why at the end of the tunnel here, you will have a dilatation simply because it goes up.
Okay.
Okay, so therefore that's it. Dr. Joseph, and to all of you, let it be known that the normal ureter by ultrasound, it really cannot be seen normally because of the presence of obstruction of the air by the bowels. But if it is dilated because of an obstruction, you can see a big dilated ureter. But if it is a normal, you cannot really see the ureter because it is being obscured by the bowel gases. Okay. So, Dr. Curitana, you know the meaning of this, diba? So, it makes a lot of meaning to you.
Yes, po, Doc.
Okay, So, for example, we'll add more because you're now adding more knowledge one. Because remember, this is a blended learning. The goal actually now of Zoom with our class in RTR. That's why I love to mix first year, third doctor, first year. It is what we call as blended learning. Blended learning. This is blended learning. This is integrated learning. Actually, I'm more comfortable. Actually, Kuya Joseph and his classmates know about it that I am actually an integrated teacher. I have been when we were there first year. We love to integrate everything. It is not just because it's physio only there. We integrate everything: anatomy, physio, psychology, everything. That's why when I just don't know, maybe lucky enough that when this pandemic came, blended learning actually became a fad, Dr. Joseph, diba? That's why I'm actually happy, diba? I'm happy that it is a fad because it should be. This should be the way, diba? Integral learning. Okay. What do you call, Dr. Joseph, if for example this the aorta, diba? The aorta, abdominal aorta.
Yes, Doc.
If this will become dilated, simply because there's an let's say an atherosclerosis or a thrombus formation, that produce a thrombosis. It is a thrombus. You will have a hypertension of your abdominal aorta. So when this becomes distracted the wall simply because of the thrombus, it will become dilated. What do you call that? Aneurysm. Aneurysm. Dilatation and the thinning of the wall of the aorta. Aneurysm. So remember that if for example you will have a patient doctor, a doctor that is pulsatile a pulsatile mass, hypertension, let's say the BP, Dr. Joseph, is 220/100, my God, it's high, let's say 110, okay, and then the patient came with a mass in the abdomen and it's pulsatile ba? It's big, okay, and when you did an ultrasound, actually, you notice that the aorta was so dilated, and then you notice first that the lumen is, you notice that there were some white here, that the thrombus, the atherosclerotic thrombus. And then when you measure the lumen, or you say normally, look at this, normally as the aorta goes down, it is from 3 cm here, normal niya diameter ng aorta, 3 cm. Then at this level, at the mid, it becomes 2 cm normally. Then at this level here, doctor, it should be 1. Oh, di ba? This like a 1, So the RAM is this 1. At the level of the junction of the crossing to become the right hand iliac, it's already 1 cm. Now, they say that aneurysm is more than 3 cm daw of the diameter of the aorta. You say, di ba, in your textbook, di ba? 3 cm. But remember, in the thoracic wall, in the aneurysm, thoracic and the thoracic aorta, yes, it's 3. But if you notice talaga, if you try to look, as it is in the abdomen, di ba, normally it becomes smaller, di ba? Smaller in caliber actually, because di ba, it will become like that, di ba? So it's actually from the most proximal portion of the abdominal aorta, it is 3, still 3. But going to the mid, becomes 2 actually. Then at the distal third portion, it becomes 1 na. So, if you make the question is this, in the board exam, it goes this way. The most common site daw of aortic aneurysm is A, thoracic aorta, B, abdominal aorta, letter C, both, letter D, none of the above. What is the answer? The most common site is of aortic aneurysm is actually the abdominal. Letter B is the answer, abdominal aorta. And if the question is this, where is the most common site of abdominal aorta aneurysm, of the abdominal aorta? Of the abdominal na, it is actually the infrarenal. Not the suprarenal. It's the infra. So it is actually this area. Diba, this is the renal? Diba? So this is the most common. Okay, so it is 3, 2, 1. So therefore, do not take absolutely that these things, Doc. Kasi Doc, I measured kasi that I have measured, doctor, that for example, you were the radiology, you did, this is just an example. You decided actually, Dr. Joseph, to become a radiologist. So you took radiology residency. Then you made an ultrasound of a patient that was pulsatile, having a pulsatile mass, pulsatile mass. It's like that, okay. It was really pulsatile, and you were suspecting, doctor, that is really aneurysm. But when you measured, kasi, so you notice that there on the wall, there were some white thing there on the wall. So Dr. Joseph, what you did is you measured the lumen, because you're after the diameter. You measured, say, doctor, I measured it. It is doc. It is not dilated man, doc, but it is 0.3 man lang. 0.3 ba? 0.3. 0.3. It's less than 0.1. There is at less than 1 cm. 0.3. No, Doc Joseph, you measured it the wrong way. You should measure from here to there. Because remember, the thrombus is within the wall. The thrombus is within the wall. So measure it from here. When I measured it, Doc, it is already, actually, Doc, it is 1.5. Okay, 1.5. Yes, Doc, this aneurysm. But Doc, the book says kasi it is 3 cm. No, do not take things absolutely. Because remember, from 3, it becomes 2, it becomes 1. So therefore, expected mo dyan should be 1. But it is already, from here kasi, from the outermost portion, because it's a thrombus man, you include that one. Here, it is 1 point, it is aneurysmal dilatation already. It is aneurysmal. Plus the fact that you see, it is pulsating. use your head. Kung sintindi common ba? Common sense. It's aneurysm. Okay, ha? So, the so-called 3cm, more than 3 is actually a general term. Ha? But if as you go down, actually, it's getting smaller. Okay, so what is, another board exam question is, the turning point, the most dangerous diameter of an aneurysm that it can go into a point of rupture is what? 5. Huh? If you measured already 5 cm, for example, here, more than here at the upper, you notice that it is more than 5, it is at the brink of rupture. Huh? So refer immediately because it can rupture anytime, the 5 cm. Huh? So, but Dr. Joseph,
Yes, Doc.
you measured it here kasi in the infrarenal. The most common kasi is the infrarenal. So do not believe on that absolability. It's just good for the examination, for the board exam, 5 cm. But if you measured actually already from this side back, here, from this side going there, the outermost portion, including the thrombus, you measured it at 3 cm. My God, it's about to rupture gihapon. But it's already very big because supposed to be only 1 here. Huh? So,
Yes, Doc.
again, sentido común. Huh? Sentido común ba? Common sense will tell you. But if it is at the thoracic aorta, it's all right, doctor. You can use the 3 cm and 5 cm rule. Huh? If it is more than 3 cm, aneurysmal. And if it is 5 cm, it is about to rupture. Including if it is at this portion here, at the proximal portion of the aorta. Huh? But if it is at the infrarenal, try to think twice. Huh? Okay, we go. So that the ureter has constrictions, ureteropelvic junction at the crossing of external common iliac and the site of entrance to the urinary bladder. Okay, ha? So don't forget that that it is the third eye ureterocele, cobra head deformity. Okay, ha? So it is actually a blockage there at that area. That's why it looks like that. So therefore, if you have Dr. Joseph and company, a blockage there, congenital blockage there, why God, it can, the urine cannot just get out. The urine cannot just get out. So because of the blockage, it will go up. Huh? It will reflux. And if it will reflux, you will develop pelvicalictasia. Urine going up is not normal. This is deadly because this is a urine. This is very dirty. Huh? Therefore, you will be creating always UTI. Huh? So, Dr. Joseph.
Yes, Doc.
If you have a patient, a pediatric patient that is having recurrent UTI, always having recurrent UTI, you give an antibiotic now. This month, and next month, antibiotic na naman. Is that the child is always getting back to you. Try to think twice that it is not just an ordinary UTI. It might be a cause of a congenital thing. Huh? It could be uretero-vesicle junction obstruction, or probably, if it is a child, most likely might be dealing here a case, doc, of uretero-vesicle reflux. Uretero-vesicle reflux simply because, doc, for example, when you say uretero-vesicle reflux, Dr. Joseph, a common thing for those pediatric patients with recurrent UTI, those with 2 years old or 1 year old, always having recurrent UTI, it's not normal. If you give an antibiotic, okay, pwedeng mawara. But if it is recurrent always with antibiotic, there's something wrong. And one common thing is the uretero-vesical reflux. You know what happens with uretero-vesical reflux here at the uretero-vesical junction? The valve is immature. The valve does not close. The valve could not close immediately. So what happens, doctor? If the valve is immature, it would not close immediately. Once you have already excreted kasi a urine going to the urinary bladder, once this fills up, once this fills up, the urine, because the valve kasi does not close immediately, it will reflux. Huh? You call that uretero-vesical reflux. And therefore, you will be creating always going there, going there, going there. So once it going there, you will have recurrent UTI, and it will destroy. It will destroy your ano, huh? It will destroy your kidney.
Kidneys.
So very bad. Okay. If it is stage 1, it is only reflux going here. But if it is stage 2, you notice it will go up for the reflux. Stage 3, it will be reflux with dilatation. Stage 4, severe dilatation. So stage 1 and stage 2 actually, wherein stage 2 kasi when it can go reflux, it can go up, but it will no dilatation of the pelvic junction. Stage 1 and 2 is still correctable. It can go into spontaneous resolution. But stage 3, in which there's reflux with dilatation, as well as stage 4 with severe dilatation, it is for surgery na. Huh? Again, the significance of stage 1 and 2 is that it can go into spontaneous resolution. Stage 3 and stage 4, definitely surgery for ureterovesical reflux. So if you also have, for example, cobra head deformity, still the same. It can go up, it can block, therefore producing pelvocalcification. Huh? So those are the approaches that you will do for pediatric patient. Again, so doctors, in the kidney preliminary scout film, the KUB film, ha? So this is the kidney, this is how it appears, ha? That one, okay. Doc, I cannot see the ureter. Do not expect the ureter to be seen, not unless it is dilated. That's an obstruction because you have your overlying bowel gases. You have overlying bowel gases. Like these are bowel gases. Okay. The urinary bladder, partly filled with urine. Okay. So then, therefore, the importance, doctor, if we're doing a KUB, is that please try to make watch because you might be seeing here, Dr. Joseph, persistent calcifications here at this area. You might be dealing with stones. Okay. Good if it is a calcium containing stone. You can see a stone. You can see a calcification in the scout film. What are they call this as radio-opaque? Radio-opaque, opaque ba? Opaque stones. What are examples of radio-opaque stones that you can see on X-ray? Calcium containing calcium oxalates, doc. Calcium phosphates, doc. Okay. What are stones that are radiolucent? Meaning, cannot be seen. But both of them, when you do an ultrasound, you can see both of them in ultrasound. They are white thing. Whether radio-opaque or radiolucent, they are white thing in ultrasound. But on X-ray, what are those that can be seen? Radio-opaque, opaque, they can be seen. Calcium, doctor. Calcium-containing stones, correct. Doc, what are those that are radio example, doc, ng radiolucent. Ito man, uric acid, and xanthine. Uric, xanthine. What are radiopaque? Doc, calcium oxalate and phosphate. And doc, the stone, a favorite board exam question, the stone, doc, that is formed because of recurrent UTI, Staghorn. Staghorn calculi. What is the other term for Staghorn? Which is a byproduct actually of the ammonium, the MAP, magnesium, ammonium, phosphate stones. They are UTI stones. They develop from frequent urinary tract infection, like Proteus mirabilis, like that. Okay, so again, give me examples of radiopaque stones which can be seen on the X-ray, but as well in ultrasound. Calcium oxalates, doc. Give me examples of radiolucent, with normally you cannot see in X-ray, but on ultrasound you can see.
Uric acid.
Uric and xanthine. Uric acid and xanthine. So uric acid is very popular because we have patients of hyperuricemia, diba? Those with gout, diba? And calcium oxalate is also because we have patients who have hyperparathyroid patients, hyperparathyroid parathyroidism. Also, those with hypercalcemia those with hypercalcemia patients, they can develop stones. Okay, so another good thing. Okay, so Dr. Joseph, I'll give this to you,
Yes,
this
Doc.
challenge to you. Dr. Joseph, if you have hyperparathyroidism, hyperparathyroidism, why is it that you are prone to develop kidney stones? Sige
Because
daw.
there is excessive release of your parathyroid hormone, Doc, which stimulates osteoclastic activity, thereby increasing your calcium levels in the blood.
Galing naman. Okay, very good. So, ganito yon. What is it, doctor? What is that action of the parathyroid hormone which helps actually in the absorption of your calcium in the kidney as well in the intestine? What is that? Clue. Hyperparathyroid. Clue. Ito man. D. Hyperparathyroid hormone, doc, helps in the final steps of production of the active form of vitamin D in the kidney. Remember, D is near the C. Doc, the hyperparathyroid D hormone helps in the final production of the active form of the vitamin D in the kidney, doc. This D kasi, this vitamin D helps in the absorption of the calcium in the kidney and in the intestines. Ha? Kuha mo. Oh, ito man, look at this RAM. Hyperparathyroid, D and C. So what? If I, for example, doc, I have a tumor. For example, doc, I have a tumor of the parathyroid. So therefore, I will be producing lots of parathyroid hormone. So therefore, if I have lots of parathyroid hormone, the more that there will be activation, I will be producing more of vitamin D, the active form of vitamin D. So therefore, there will be more absorption of calcium. Diba? So the more absorption will develop, of course, calcium stones in the kidney. What else? What else also would be the effect? You mentioned about osteoclastic activity, di ba? The parathyroid hormone actually maintains the normal
density of the bones.
Normal density of the
bones.
No, actually, no, it's not. Actually, ganito yon. For example, this is the bone. This is the bone, doctor, ha? Okay.
Yes,
The parathyroid hormone normally the parathyroid hormone actually prevents osteoclastic activity, prevents osteoclastic activity of your bone because no, sorry, ganito muna. Normally the parathyroid hormone helps actually in the regulation of the normal calcium blood levels, right? That's why the parathyroid hormone, we need parathyroid hormone so that it will activate it will activate the final stages in the activation of the vitamin in the kidney so that it will help in the absorption of the calcium. That's why in our blood, let's say the calcium is being maintained normally, right, doctor? Because we are reabsorbing calcium from the kidney and from the intestine, right? Then, doctor, normally also the parathyroid, for example, this is the bone. Normally it is the obligation of the parathyroid hormone to have normal resorption of the bone, meaning normal osteoclastic activity, because the osteoclasts, they are the one with help try to deliver resorption, meaning resorption, you try to remove normally small amount of calcium from your bone so that it will, the osteoclast, diba? They class osteoclastic activity, they resorb the calcium here in your bone so that at least a part will go to the blood, diba? To maintain your normal calcium, ha? Okay, but remember, that is a normal activity, meaning to say, it is just a normal thing to the extent that you do not develop a bad bone. You do not develop a bad bone simply because it is just the normal amount of calcium that is being resorbed going to the circulation, huh? Meaning there is no abuse, because that is just a normal phenomenon, so that you can maintain your normal calcium. So you don't see therefore changes in the bone. You just see that normal usual white thing. Now, if you have a tumor of the parathyroid gland, what will happen? There will be more activation of the vitamin D, therefore more absorption of the calcium, more calcium in the blood, therefore more calcium deposition in the kidney, diba? So you will have prone to development of stones. Now, another effect is that if you have too much parathyroid hormone, what will happen? You will have too much osteoclastic activity, doctor. Diba? Too much. Huh? So you will have too much resorption of the bone. Therefore, too much removal of calcium from the bone. You will therefore have an greatly increasing calcium. Huh? So therefore, you will develop stones in hyperparathyroidism. O, doctor, kuha mo. And what is, another board exam question, what is that tumor, not actually a tumor, but an expression that because of hyperparathyroidism that produce too much osteoclastic activity, therefore resorption of the calcium there to be removed from the bone, you develop therefore a lytic change in the bone. If this is white, for example, this example lang ha, this is the usual white bone, ano, and then just increase this black thing, increase it more in a hyperthyroid. Therefore, that black thing, you can see that one, but the surrounding is white. What do you call the tumor? It is actually due to the fact that there has been too much demineralization or calcium removal from this area here because of hyperthyroid. You call that as brown tumor. Remember in pathology, huh? Brown tumor. Diba? In Robinson-Cotran, it is actually a bone change, not actually a tumor. That is due to the fact that there has been too much osteoclastic activity on that or too much resorption as a consequence of too much parathyroid hormone. Huh? Okay, huh? So you call that as a brown tumor. Okay. Okay. So again, calcium-containing stones are calcium oxalates, the struvite or the staghorn, triple phosphate stone, struvite, okay, or pure calcium phosphates. Radiolucent examples are urics, uric acid, xanthine, cystine stone. Ito man, urics, cystine, urics, xanthine stone. While those that are opaque are calcium oxalates, struvite, pure calcium. Okay, so again, so going back, so therefore, parathyroid, okay, parathyroid, the hormone actually helps in the final activation stage of the vitamin D. What is that active vitamin D? Dihydroxycholecalciferol. It's just like because you have two kidneys, man. Okay, so therefore, if you remember, what are the stages in the activation of vitamin D? Because you can take vitamin D, not just, you will have also vitamin D, not just from the foods that we eat, but also from the sun. Okay, in your skin, doctor, in your skin, this is the skin, doctor, skin. What is that form of inactive form of vitamin D in the skin, which if active by the sun, will become a precursor for vitamin D. Okay, the skin is dehydrated. Okay, the skin is dehydrated, and this cadaver, dehydrocalciferol, di ba, Dr. Do you remember, Dr. Joseph? Dehydro. Yung clue ko dyan, yung ram ko, my ram is there. This is sun, I have here a skin. My skin gets dehydrated. And what is that form there for vitamin D? Dehydrocholecalciferol. so that you would confuse it with dihydro. Dihydro demand to the kidney. Okay. Then it will go to the liver. It's the liver here supposed to be, huh? The liver, it reminds me of the bile in the gallbladder. It's watery. So what is that form? Hydroxy huh? Hydroxy, like watery. So from dehydro, it becomes a hydroxy. Then the final stage is in the kidney, which is dihydroxy cholecalciferol. So it is the parathyroid hormone helps in this one, huh? Dihydrocholecalciferol, and therefore it now absorbs the letter C, the calcium, which is near the D, the calcium. So calcium absorption in the kidney and as well in the intestine. So therefore, if you have hyperparathyroidism, you will have more calcium being absorbed and you will have hypercalcemia simply because there is as well, di ba, as I told you, there is as well resorption. Huh? More calcium will be delivered also here. So you'll have hypercalcemia, another site for stone formation. Huh? Okay. What's your time there, Dr. Joseph? What's your time?
Doc, it's 10:54.
Okay, sige. Okay, ha? So, like this. Okay, good, good. Ha? So, you now remember that. So, break daw tayo muna. Break lang muna tayo. Have a little something to eat, Doc. Okay, what's your time? 10:54? Dr. Joseph?
10:54, Doc.
At 11, sige, at 11:05, we come back. Kahit di naman may matapos. So, we don't just that off. Just break lang tayo. Take a little milk or then go to CR. Ha? Take a little bread. Break. So, at 11:05, we continue, ha? Okay. Sige, thank you. Ma'am Raquel, break lang kami, ha? 5 minutes. Wala siya, oh. Okay, hello. Everybody in na? Hello. 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 Joseph. Hello, Cindy. Diyan na kayo? Hello, Dr. Cindy. Oh, sige. Okay. Okay, ano pa sa time na? Sige, 5 minutes pa ba, no? 5 minutes break pa? Pera pa.
It's already 11:01.
Oh, sige. 4 minutes more. 4 minutes. Sige. We'll start 11:05. 4 minutes more. Tell me, Joseph, kung 11:05 na, ha? Hello, Doc Cindy. Doc Cindy. Doc Cindy, please prepare. You're the next reactor, ha? Okay. Okay. We'll be dealing about mga reabsorption na, mga filtration. So dito, ha? Okay, so we start na, ha? Okay, so Dr. Cindy, hello. Hello, Dr. Cindy. Okay, so, di ba, we discussed about the process of the urine formation, di ba, is the filtration, di ba, tapos reabsorption and then secretion, ano? And then, whatever is the result for this one, we should be excreting out. Okay, so, what are the, give me the examples, Doctora, of filtrable substances. Filtrable. So, flu, Doctora, glucosa. Glucose, ano pa? urea, this one. Also, oh yeah, water, sodium, di ba? Amino acids, very good. Okay. To add it up, I'll just add this up, ha. When we say oncotic pressure versus osmotic pressure, what is osmotic pressure versus oncotic pressure? When we say oncotic pressure, that is the pressure that is actually affected by the presence of the protein in the blood, particularly the albumin. When you say osmotic pressure, it is not just the proteins, but as well the ions, other ions in the blood. That's why you call it osmotic pressure. And the other one is oncotic, because so you say plasma oncotic pressure, that is the pressure generated by the presence of the protein, particularly the albumin, in the blood. When you say plasma osmotic pressure, aside from the proteins, there are ions as well. Di ba? Sodium, di ba? Potassium, that's osmotic pressure. That's it up. So, doctor, so the next is that when we, okay, so, doctora, why is it, doctora, that even if we have Doctora Cindy, if we have in the afferent arteriole, here in the afferent arteriole before it goes, we have also proteins. We have proteins. We also have red blood cells. Why is it, doc, that they usually do not go to the urine? That's why usually our red blood cell is only 0 to 2 or 0 to 1. Our white blood cell is usually 0 to 2, like that. Taton proteins is usually negative to faint. Why is it that usually they don't? So, first and foremost, my clue is that, therefore, what is in this one? What is the so-called renal filtrating membrane, docs? I'm going to lead you. What is the so-called renal filtrating membrane? What are the 3 layers? Oh yes, the glomerular endothelium, then the basement membrane. Oh yes, and then what is this? The podocytes, or the visceral layer of your Bowman's capsule. So, therefore, as you told, so, sige lang, ha? Okay. I will just a survey first. So that, okay. Doon na lang, ha, kahit para makakwanta kami. We have to discuss, we have to stop before 12 because so that we can also eat. Okay. So, this one, this is important, the renal filtrating membrane, di ba? So, first and foremost, thank you, Dr. Actually, I appreciate you, you were able to answer. No problem. So, we'll continue na lang, ha, we will be lacking time. So, this also the glomerulus, ha? So, don't forget the nephron is composed of the renal corpuscle, which is composed of the Bowman's capsule and then the glomerulus. The Bowman's capsule has a visceral layer and a parietal layer. And another part, aside from the renal capsule, will be the tubules, which is composed of the proximal convoluted, the loop of Henle, the distal convoluted tubules, and other physiologists, the collecting duct, and other radiologists, not collecting duct. No problem about it. So now, remember that this one is very important because the endothelium of your glomerulus, we have the endothelial cells, it's being lined. So therefore, the endothelial cell of the glomerulus, like for example this one. So it has pores. It has pores in between. Pores or fenestra. Okay, pores or fenestra. That's why normally the red blood cells here cannot get out because actually the red blood cells are bigger. Now the next layer is the Bowman's. So the basement membrane. Then this one is the podocytes. The visceral ba? It is actually composed of like podocytes, like that, mga cells. So they're interdigitating another one. So they like food processes. So in between the food process, they have slits, filtration slits. So we should have filtration slits here like this. Here. Okay. But normally, di ba, according to you, Doctora, normally Normally, the proteins, actually, they can get out. They can get out, di ba? Here, because they can, but the red blood cells cannot. But the albumin, it's still very small. It can actually get out. But the good thing is that the albumin kasi, di ba, the albumin of our blood, albumin, take note of this ha, the albumin of our blood is negatively, albumin and is negatively charged. And that the renal filtrating membrane is also negatively charged. This negative. So, Dr. Cindy, di ba, negative to negative poles will repel. That's why the proteins cannot get out normally. That's why you have 0 to 0 to 2 tayo na red blood cell, 0 to 2 tayo na, or faint lang tayo na protein. Okay. So, Dr. Joseph, therefore, in nephrotic syndrome, di ba, congenital yan, di ba? The baby has been born with that. It is actually because of the charge. There's a defect in the charge. Supposed to be, the renal filtrating membrane is supposed to be negative. Albumin is supposed to be negative, but in a child with a nephrotic syndrome, that there is the loss of the negative charge of the renal filtrating membrane. It becomes positive. That's why the albumin can freely get out because it's being attracted. That's why there will be losing of proteins in the urine. So you will have albuminuria, but you will have hypoalbuminemia. So if you have a hypoalbuminemia, you have a decrease only na protein here, natural, the tendency for the fluid would be to go to the interstitial space, di ba? The interstitial space, because there's more absolutes here. So therefore, the subcutaneous will be watery, therefore you will have edema, extracellular edema, okay? But in the urine has no red blood cells usually. There's no hematuria usually in nephrotic. Only albuminuria. But in glomerulonephritis, which is post-streptococcal, after 2 weeks kasi of infection with streptococcus in the sore throat, you will develop autoantibodies, di ba? Antibodies to your own renal filtrating membrane. You will develop antibodies to your renal filtrating membrane because it is an autoimmune disease. So you will destroy your renal filtrating membrane. Therefore, if you destroy your renal filtrating membrane, the red blood cells can get out because the pores will widen. And then the renal filtrating membrane will also have an increased permeability. Will have an increased permeability. So therefore, proteins could easily get out. So because you will also have albuminuria, and because the destroyed man imo renal filtrating membrane at tapos an imo, therefore an imo pagod membrane, renal filtrating membrane, pud man imo pores, di ba, imo glomerulus, they're included. So therefore red blood cells would get out. That's why you have hematuria as well. Okay. So that's why the presence of blood in glomerulonephritis, but no presence of blood in nephrotic syndrome. But all of them would have edema. Edema. Okay. Extracellular type of edema. Tapos kita nga ni Dr. Cindy nag-aram pa kita gyapon yesterday about di ba, about intracellular edema, di ba? What happening in the brain, and we also had pictures. Anyway, I don't have to show them once at the fourth year because they already know that one. But at the same year, first year, di ba, we have expanded our studies with the pleural effusion, pericardial effusion that develops as well because they are forms of edema, di ba? The pleural effusion, pericardial effusion, ascites, they are forms of edema, di ba? But they occur only in the compartment space. Okay. Okay, so we go further. Now, Dr. Cindy, continue, Doc Cindy. So we have filtrable substances. So they will now go to the proximal convoluted tubule. The proximal convoluted tubule True or false? The greatest reabsorption actually of those filtrated will be in the proximal convoluted tubule. True or false? Huh? True.
True.
Because 65% of those filtered will go to the proximal. So water, 65%, the water that will filtered, the sodium also will be reabsorbed. Glucose will really be absorbed there in the proximal convoluted, will be reabsorbed. So will be reabsorbed. And where they go, Doctora? Well, where they go? So they will go to the proximal, where is the proximal convoluted tubule here? So proximal convoluted, they will be reabsorbed. They will go to the interstitium, and they will now go to the, where, Doctora? To the peritubular capillaries. Huh? Okay, they will go back to their body, to the heart, to the blood vessel. But somewhere along the way, Doctora, you told us that 65% man lang talaga reabsorb. So may dapat talaga, there's an Indian kasi, we have an Indian, we have a Duri here, so I speak English. So we go now to the distal, we go now to the descending limb of the loop of Henle. So in the descending limb of the loop of Henle, Doctora Cindy, of the remaining 35%, what is reabsorbed here at the descending? Water only, very good. Only water. Okay, only water. So it will be reabsorbed again, water. Okay, going here to the peritubular capillaries, interstitial, for example, capillaries. Okay, now, but remember, there will be still some water that will go, but the sodium kasi was not reabsorbed because it's not permeable to sodium, only to water and other solutes. So we'll go down here, di ba, Doctora? So therefore, no wonder, as you go down deep, di ba, this, for example, this is kasi a juxtaglomerular nephron. So as you go down deep, which is very important for the concentrating, the sodium therefore gets increasing here, because more water were reabsorbed. So, and then as you go up again, the ascending limb, in the ascending limb of loop of Henle, Doctora, what is reabsorbed? Water or sodium or both? In the ascending limb, Doctora Cindy. Oh, acin, sodium. Okay, very good. So it will go back there. It will go to the peritubular capillaries. Okay, very good. Okay, and then so far, some sodium and then some water will of course continue. Will continue here. Going there to the distal convoluted tubule. Now in the distal convoluted tubule, Doctora, water and sodium has still to be reabsorbed, right? Because some will able to go pa naman talaga up. What is that hormone, Doctora, in the distal convoluted tubule that is absorbed by the body that will act on the distal convoluted tubule so that, Doctora, the sodium will be reabsorbed back going to the to the interstitial space and then going to the blood here in the peritubular so that water will follow. What is that hormone, Doctora? In the distal. Correct. Very good. Joseph, believe ka daw first year, ano? First year, ha? Nagusugad-sugad na, ha? Okay, nagraram na kasi tira, nagraram na. Pero yung ano na, di ba? Di ba, I also developed you that way before first year.
Yes po, Doc.
It reminds you of your first year, ano, Joseph? It reminds you, di ba? When you were still first year, I was doing it to all of you, di ba? Oh, I was doing it to all of you.
Medyo very interactive.
Yes. Kamu dira printe, ikaw, Jong, kuan Indian, the other one, ano to? All of you, man. Corina also. I always call her. Di ba? All of you, man. Only that Jong kasi is ano, Jong kasi is Jong kasi is ano, crocodile. Always reciting. Not crocodile. What is crocodile in Bisaya? Ano, diba, basketball player kan, Indianos. Ano ito? Crocodile? Buhaya, di ba? Buhaya.
Buhaya yan,
Di ba?
ito.
The basketball player,
Excitation.
buhaya, always, the ball is always with him. But Jong is like that also. No problem because it makes participation very alive. Okay, no problem.
Yes.
So, okay ha? So, aldosterone, don't forget ha, aldosterone at the distal convoluted tubule will allow the sodium to go inside aldosterone so that water follows. So aldosterone not acts not only here in the distal, Dr. Cindy and everyone, but also in the collecting ducts. Also in the collecting ducts. Okay. Now